thanks to the screening programs that are operating in many parts of the world, a significant proportion of patients with liver cancer will be diagnosed at an early stage of their disease, having the so-called small liver cancer, which is suitable to radical therapies with a high potential of cure. And when designing a strategy to treat patients with a small liver cancer, disease severity, patient's age, and the potential of other comorbidities should be taken into account to make the right choice. The very few patients that have a perfectly normal liver of a mildly diseased liver, possibly less than 10% of the overall population, can safely be treated by limited hepatic resection. The vast majority of patients with a small cancer will have an accompanying liver disease that in most instances is actually cirrhosis. And now the situation differs according to severity of liver disease. Those patients having a very well compensated liver function may still undergo limited hepatic resection if the tumor is small enough and located at the periphery of the liver. For those patients who do not fit criteria for resection because they have severe portal hypertension or other liver or non-liver related complications, radiofrequency ablation, which means inserting a needle into the tumor under ultrasound guidance and delivering heat, is a safe and effective procedure that might provide 70–75% chances of being alive 5 years after the operation, however, with an elevated risk of tumor recurrence. For those patients who do not fit criteria for hepatic resection or radiofrequency ablation and have therefore a more impaired liver function, provided their age is optimal, less than 70, and they are devoid of important comorbidities like severe diabetes, myocardial infarction, other tumors, so on and so forth, these patients' populations can be considered for liver transplantation. Liver transplantation in cirrhotic patients with a small tumor provides between 60 and 80% chances of being alive 5 years after the operation without recurrence of the tumor. Of course, in the case of hepatitis C, there will be the additional toll of recurrent hepatitis that needs to be treated with appropriate strategies. Ultimately, there is a population of patients that do not perfectly fit these broad criteria of treatment because the liver is well compensated, but the tumor is a little bit higher, bigger than that is required to be safely treated by radiofrequency resistance, for instance, between 4 and 5 centimeters. Well, this set of patients could benefit from an integrated therapeutic strategy, which means applying in sequence radiofrequency ablation or chemoembolization.